Muy buenas, bienvenidos a esta sesión de AJL Ophthalmic. AJL Ophthalmic es un líder mundial en el tema de las lentes, y sobre todo de anillos corneales para el tratamiento del queratocono. Y esta sesión precisamente busca poner una actualización en el manejo del queratocono y también de hablar acerca de los resultados en términos de seguridad y eficacia. Tenemos un distinguido panel en esta sesión que está copresidida por Heykel Kamoun de Túnez. Participarán a continuación Luis Fernandez Vega Cueto, Carlos Gordillo, Heykel Kamoun y Belén, Alfonso, y habrá una discusión en forma de panel con Jorge del Barrio y Belén, Alfonso como protagonistas. Así que bienvenido a la primera presentación que corresponde a Luis Fernandez Vega Cueto. Adelante.
Hello, everybody. Thank you very much for the invitation to Dr. Alió. It's a pleasure for me to participate in ARI 2025 and also to AJL for the trust in us. These are conflicts of interest, and the study will be the intracorneal ring segment implantation in pediatric patients with keratoconus and the analysis of the long-term results. The implantation has to be in patients under 18 years old in order to get inside the study. The setting is the Fernandez Vega Institute in Oviedo. As you all know, we classify the conus in 6 different phenotypes, 1 with high asphericity, which is the nipple, and 5 with low asphericity. One of them is central, which is the bow tie, and the other 4 are paracentral or peripheric. And this is very important to classify the conus in order to implant the intracorneal ring segments. All these phenotypes have a very good efficacy and safety, and all of them have been published in the literature, so you can have a look at each one separated. The progression criteria approved in the bibliography are the pachymetry, the max K, and the visual acuity, and there are also others like refraction, anterior and posterior elevation, and curvature map. We've published some years ago the stability of the intracorneal ring segments in this population, in pediatric population, but up to 5 years. And this is why we are going to see today how this treatment behaves in patients up to 18 years old, but with a follow-up of 10 years. We have a sample of 107 eyes, and the most common one, the most frequent one, is the high asphericity keratoconus. That, as you all know, is the most advanced keratoconus. The efficacy index is 0.75 because you know that the sphere is not corrected by the rings. That's another issue. And the safety index is 1.23. So everyone equals or gains lines of vision. Those are the results at 1 year. So intracorneal ring segments is an efficient and safe procedure at 1 year for the visual rehabilitation of keratoconus patients in pediatric age, because it reshapes the corneal morphology and improves visual quality and also induces a regression of the disease. We will see if the induced visual rehabilitation is sustainable over time, for how long, and how can long-term success be defined. The progression criteria between visits would be a Kmax increase of more than 1.5 diopters, refractive or topographic astigmatism increase of more than 1.5 diopters, and loss of more than 1 lines of vision. Success would be no progression criteria in the evaluated visit. Partial success, 1 or 2 progression criteria were found in the assessed follow-up, but the results have improved compared to the preoperative period, and failure, 3 progression criteria, or we perform keratoplasty in those patients. In the period between 1 to 5 years, 89 eyes were evaluated with a success rate of 84%. 8 eyes showed 1 or 2 progression signs, 3 eyes showed 3 progression signs, and 3 eyes needed a DALC. In the next period, between 5 to 7 years, we evaluated 69 eyes and with 85% of success. We had 6 eyes of partial success and 4 eyes of failure, but those 10 eyes came from the period between 1 to 5 years. So we didn't have new cases of partial success or failure in this new period, and no new keratoplasties had to be performed. Those eyes came from the period between 1 to 5 years. And the same happened in the next period between 7 to 10 years. We evaluated 36 eyes with 88% of success, and all eyes of partial success and failure came from the period between 1 to 5 years. So in summary, partial success or failure appeared, all of them, in the period between 1 to 5 years. All cases considered success showed stability across all parameters and throughout all the follow-up, as you can see in the screen. And of the 8 eyes that had considered partial success in the period between 1 to 5 years, 3 of them had 2 signs of progression and 5 of them had only 1 sign of progression. But remember that all of them improved compared to preoperative period and remained stable during the whole follow-up. The treatment was successful in 85% of the cases, and this percentage rises to over 90% if we consider that all partial success were in better condition than before surgery. And if we compare the rates with cross-linking, we see that cross-linking has different progression rates and with a percentage of complications that we have to take into account. Young age means more progression rate, but also the phenotype. Hyperprolate phenotype has more progression rate than other phenotypes. And remember that it was the most common one in this study. Why this could be happening? We have to have a look to the biomechanics, because there is an increase of central corneal stiffness until intracorneal ring implantation, and also the presence of the ring limits the width of the formation. The rings induces a redistribution of the tension, deformation, and stress, and they act as an artificial limbus, improving this way the corneal biomechanical response. In conclusions, pediatric keratoconus correction with rings is an effective, predictable, and safe procedure that demonstrates stability, at least comparable with other techniques. More than 90% of the cases treated with rings are successfully or partial successful. Keratoconus should be classified into phenotypes to identify at-risk cases and establish the appropriate correction strategy. Younger patients and those with hyperprolate phenotypes are at greater risk of long-term instability, and there were no complications such as an infection or extrusion of the ring through all the follow-up period. Thank you very much for your attention.
Thank you very much, Luis. Now we have the presentation of Carlos Gordillo from Argentina, dealing about Cairs or intrastromal rings. What is the difference, what is the outcome, and how they should be indicated. Thank you, Carlos, for being here today, and you are the next. Thank you.
Buenas tardes, soy el doctor Carlos Gordillo desde Mendoza, Argentina. Yo soy jefe del Departamento de Córnea del Instituto Saldívar y vicepresidente de SACRIC, Sociedad Argentina de Córnea, Catarata y Refractiva. Agradecido por la oportunidad de participar en este congreso. Mi idea de esta presentación es presentarle justamente cirugía aditiva de la córnea y entender cuáles son las indicaciones tanto para anillos intracorneales como para Cairs. Básicamente lo que tenemos que entender en esta presentación es que existen diferentes técnicas de cirugía aditiva de la córnea y mi idea es presentarle casos, pero siempre entendiendo que cada caso tiene un abordaje personalizado. Entonces, ¿qué tenemos que tener en claro a la hora de abordar a un paciente con keratocono? Que hay que detener lactasia en el caso de que sea progresiva, hay que regularizar la córnea y hay que reducir las aberraciones ópticas. Básicamente, si hablamos de cirugía aditiva de la córnea, observamos que desde 1949 hasta hoy, en la fecha se han progresado muchos avances y hoy en día podemos hablar de una clasificación de cirugía de anillos intracorneales de PMMA o cirugía aditiva de Cairs. ¿Cómo abordo yo mis pacientes o cómo los elijo? Básicamente los anillos intracorneales de PMMA siguen siendo aceptables y con excelentes resultados para pacientes con estadios 1, 2 y 3, con paquimetrías mayor a 400 y keratometrías menor a 57. Para aquellos pacientes que tienen paquimetría menor a 400, estadios muy avanzados y keratometrías elevadas, puedo utilizar los Cairs con muy buenos resultados. Entonces, para ambos casos sí debemos optimizar tanto la selección del paciente como la topografía, cómo identificar los ejes cromáticos refractivos y topográficos, para así poder elegir si Cairs o anillos intracorneales. Mediante casos les voy a mostrar algunas alternativas de elección. Vamos con este primer caso, un paciente que tiene una agudeza visual de 20-50 en su ojo derecho, que no corregía con corrección a más de 20-30, con un astigmatismo bajo, con un cilindro de 2,75, ojo izquierdo, básicamente para controlar. Entonces vemos que las aberraciones ópticas de este caso se encuentran elevadas, trazo las líneas de identificación de ejes cromático, refractivo y topográfico, y para este caso, al tener más de 30 grados de diferencia, utilizo un anillo intracorneal de PMMA asimétrico de 6 milímetros, realmente con excelentes resultados. Pueden ver su pre y postquirúrgico como luego de implantado mejora la calidad óptica por reducción de las aberraciones, y acá podemos ver un mapa comparativo pre y postquirúrgico mediante solamente la implantación de un segmento. Básicamente en este caso tenemos un resultado tanto terapéutico como refractivo en simultáneo. ¿Qué hacemos con aquellos casos que tienen miopía mucho más elevada, también asociada, además del astigmatismo? Como pueden ver, en este caso se trata de un paciente con un croissant en su ojo derecho, y en este caso voy a optar por un segmento simétrico, ¿sí?, de mayor espesor, de 150 grados con 200 micras. En el ojo izquierdo tenemos, al igual que recién, más de 30 grados de diferencia entre sus ejes, por lo cual voy a implantar un segmento asimétrico. La implantación de este segmento no difiere mucho de los tradicionales, ya que vamos a utilizar una profundidad del 80% como siempre. ¿Sí? En este caso, los túneles pueden ir variando según cada médico y según cada cirujano. A mí me gusta utilizar túneles anchos para poder evitar que realmente sea un segmento ajustado. No es mi intención en este concepto. Luego, a la hora de implantarlo, no difiere de la técnica habitual a través de la incisión y luego desplazándolo por el túnel hasta tener la posición final del segmento. Entonces, para estos casos podemos observar que en ambos casos hemos tenido una recuperación de cantidad visual, pero a pesar de eso tenemos una metropía residual bastante importante, ya que mi tipo de abordaje del queratocono es siempre terapéutico en un inicio y luego poder determinar cuál es la vía refractiva. En este caso fue una lente fáquica, un ICL tórico, para poder corregir su astigmatismo y su ametropía residual. Podemos observar que la técnica no difiere de la técnica habitual. Hacemos las incisiones como es tradicional y luego el cálculo del ICL se hace considerando la agudeza visual subjetiva, como lo hacemos habitualmente. En este caso hacemos el implante del ICL como habitualmente, y una vez que se encuentra en su posición final podemos observar cuál es su volt y determinar realmente cómo el tipo de lente ha corregido la cantidad de agudeza visual que necesitamos. Podemos observar ahí cómo se encuentra el lente en su posición, el anillo intracorneal, y esto es a las 24 horas de implantado. Como pueden ver, el resultado final es maravilloso, con una agudeza visual sin corrección prácticamente nula. Y también pueden ver acá cómo se corrige la aberración óptica. Realmente increíble cómo puede esta técnica favorecer a nuestros pacientes, en este caso en ambos ojos, con una alta predictibilidad a la hora de realizar el cálculo y el implante de los mismos. Ahora, ¿qué vamos a hacer en el caso de un paciente que no tiene suficiente espesor, como es en este caso? Tenemos 360 micras centrales, un keratocono central tipo nipple inducido por una miopía muy elevada, y como podemos ver en este caso hubiese sido imposible realizar otra técnica que no sea DALC o Cairs. Para este caso yo utilicé un Cairs que preparé en quirófano. Luego de hidratar el tejido y deshidratarlo, puedo preparar 2 segmentos para implantarlos. Es muy importante considerar qué cantidad de tejido vamos a implantar. Como son córneas y paquimetrías muy bajas, debemos considerar que este tejido no debe tener mucho espesor. Usualmente para estos pacientes trato de llegar a 350-400 micras de espesor mayor. Realizo el túnel con la plataforma de femtosegundo. En este caso hago un túnel más amplio, como podrán ver, y con 2 incisiones utilizando esta plataforma de femtosegundo. Luego, a la hora de implantar el segmento de Cairs, lo que realizo es la apertura de los túneles y divulsionar las lamelas superficiales. En este caso vamos a ir a una profundidad de 250 micras. Es muy importante considerar esto, ya que las profundidades difieren entre los Cairs y los PMMA. Como pueden ver acá, realizo el implante del Cairs en la profundidad deseada y luego vamos a observar cuál es la posición final. En este caso, utilicé un segmento superior e inferior y podemos ver sus resultados y cómo mejora su cantidad visual, a pesar de que en este caso tuve una metropía residual. Los resultados fueron excelentes, con buena tolerancia a lente de contacto y una oportunidad de ir a una lente fáquica. Por cuestiones de tiempo voy a pasar muy velozmente este video de un paciente que también tenía un anillo de mucho tiempo y se había obstruido por un traumatismo. Luego de extraer este segmento, esperé un tiempo para poder ver cómo quedaba la topografía final y finalmente realicé el implante de un Cairs en la posición deseada para poder reemplazar justamente la zona ectásica de la cicatriz que había quedado en este paciente. Como pueden ver, el túnel se encuentra en la periferia de la cicatriz y luego pude realizar la misma maniobra y colocar el segmento intracorneal de Cairs en el sector deseado. En este caso el túnel era más delgado, por lo cual era más complejo insertar el tejido, y acá podemos ver cómo se va desplazando hasta la zona deseada. Una vez que está implantado podemos ver el postquirúrgico, la imagen con la cicatriz y el Cairs en la posición y cómo mejora tanto su cantidad como su calidad visual. Como pueden ver acá en una gráfica de la cantidad de injertos que tengo en mi práctica, podemos observar cómo desde 2023 que comencé a implantar Cairs se han mantenido los injertos endoteliales y los injertos penetrantes, pero sí he tenido un descenso en lo que es DALF y SALC. En cambio, para los anillos intracorneales no he tenido ningún cambio en estas indicaciones, por lo cual en mi práctica diaria sigue siendo mi técnica de elección por la predictibilidad que tiene. Ambas técnicas, como conclusión, son cirugías aditivas con excelentes resultados, muy efectivas, pero claramente el PMMA ha demostrado mayor integridad a la hora de tener predictibilidad. Muchas gracias por su atención y por su tiempo.
Thank you very much, Carlos, for this excellent presentation. Now it's my pleasure to introduce Heykel Kamoun from Tunisia, a very good friend from many, many years and an expert in keratoconus management. He will talk about progressive rings, when to use them and why. Thank you.
Good evening, everyone. I am Dr. Kamoun from Tunisia. And first of all, I would like to thank Professor Alió and IGL for inviting me to this wonderful session. My talk of today will be about progressive segment, when to use them and why. As you all know, the perfect deal is to have a perfect matching between ring flattening profile and ectasia shape, because refraction is not vision, but shape is vision. As you can see here, this is the morphological classification of keratoconus proposed by Professor Alfonso. And as you can see here, we have symmetric keratoconus and asymmetric keratoconus. Symmetric are nipple, bow tie, and croissant, and asymmetric are duck and snowman. Symmetric keratoconus are mainly associated with vertical coma and spherical aberrations as the dominant high-order aberrations. However, asymmetric keratoconus are also characterized by a significant level of coma and spherical aberrations, but also with an increased level of trefoil and quadrifoil, which characterized asymmetric keratoconus. And we know today that quadrifoil and trefoil are not well treated by symmetric rings. In this short video, you can see the effect of basic symmetric rings, and you can notice an hemispherical flattening with variable spherocylindrical effects depending on arc length of the rings, which affect only vertical coma, spherical aberrations and astigmatism, and no effect or a slight effect on quadrifoil and trefoil. This is a nice study showing us the aberrometric outcomes of symmetric rings implantations, and we can notice a significant decrease of central high-order aberrations, especially on comma and spherical aberrations, and there is no effect on trefoil and quadrifoil. Symmetric rings fits very well symmetric keratoconus because it affects very well the most important high-order aberration of symmetric keratoconus, which are comma, spherical aberration, and astigmatism, and that's why we have a very good result with symmetric rings in symmetric keratoconus. But in asymmetric keratoconus, we have rarely satisfactory outcomes with symmetric rings because we have a discrepancy between comma axis and steepest axis, and that's why we couldn't affect the most high-order aberrations, and I will explain more in the next slide. In asymmetric keratoconus, like DAC and Snowman, we have no coincidence between comma axis and steepest axis. And today, one of the major reasons of unsatisfactory result is the significant difference between the comma axis and the astigmatism axis. Like in this example of DAC morphology, we have in red the steepest axis, in black the comma axis. So generally we put the ring on the steepest axis, and here we will treat the astigmatism but not the comma aberrations. And if we put the ring on the comma axis, we will treat comma and we will overcorrect the astigmatism. And this is the major reasons of unsatisfactory results in asymmetric keratoconus. This is the design of our new IGL progressive segment with a double progression in width and in thickness, as you can see in this video, compared to other progressive rings in which we have only progression in thickness but not in width. This is the first study published in 2021 on asymmetric rings pro-IGL in asymmetric keratoconus, and as you can see here, very good results in visual acuity and also in all refractive and aberrometric parameters. This is the new IGL nomogram including progressive segment pro-IGL, considering shape, asphericity, primary comma, and also the level of discrepancy between astigmatism and comma orientations. The best indications of progressive segments are asymmetric keratoconus like Snowman, DAC, and asymmetric croissant, when the difference between the comma axis and topographic axis is more than 30 degrees. Of course, it's very important to consider stage of keratoconus, and as we all know, lower grade, better prognosis. This is the first example of DAC morphology, and in this case we used one IGL Pro of 5 mm 160 degrees 250 micron, and as you can see here, very nice refractive and topographic results with a reduction of 4 diopter of astigmatism and an improvement of 6 lines of visual acuity. And you can see here a very nice progression of the flattening from the top to the bottom in the differential map. This is another example of Snowman morphology, and in this case we put two progressive segments, two IGL Pro of 5 mm, and we can see a very nice topographic and refractive result. And in the differential map, we can see that the flattening was in the inferior part of the topography due to the flattening progression of the progressive segment, which is the desired effect. In conclusion, the good prognosis of intracorneal segment depend on a stage of keratoconus, of course, and also adapting ring profile to the shape in order to customize the treatment. So symmetric ring for symmetric keratoconus and asymmetric rings for asymmetric keratoconus. Thank you very much.
Thank you, Heykel, for a most interesting presentation. This asymmetrical ring seems to be part of our present practice, indeed. And now the time of Belén Alonso from Oviedo. She will talk about when the alternative is a transplantation for keratoconus, which is the limit that we can reach in the treatment when nothing else is possible. Thank you, Belén, and you are the next.
Good afternoon, and thank you very much for your kind invitation. Next, we are going to present this work entitled Predesthemetic Corneal Ring in Dark for Advanced Keratoconus 5-year Follow-up. Well, the purpose of this study is to evaluate the morphological and functional results of neo-ring implantation during DALK in patients with keratoconus and analyze the results at 5 years of follow-up. As we all know, astigmatism DALK due to keratoconus could originate in the donor, in the host, or even during the surgical technique. Moreover, this astigmatism may be stable or progressive over the years. We may also have some short-term complications in patients with DALK due to keratoconus that could be secondary to Descemet's membrane ectasia, such as steep keratometry or central folds in Descemet's membrane, or secondary to thickness inconsistencies like anterior or posterior step, ocular surface disorder, or early astigmatism against the rule. However, we could also have some long-term complications, such as recurrence of keratoconus in the donor, something that is described in PK and also in lamellar keratoplasties, or progression of keratoconus in the host, something described in PK but not yet in lamellar keratoplasties. On the other hand, one of the first rings used in keratoplasty was the crewmate's ring. It was initially used in PK and was implanted at the interface between the graft and the host, between the two corneas. Its purpose was to modulate the healing, reduce the final astigmatism, and also reduce the immune reaction. Well, our group has experience with this metal ring in patients with DALK. With this procedure, we obtain good morphological and functional results with a low astigmatism, but the economic cost was high and also the aesthetic aspect too obvious. For this reason, we have considered the development of this predesthemetic corneal ring called neo-ring. And as you can see here, it is made of PMMA and has a circular section, and it is also viable in 3 diameters. Well, the objective of this implant in patients with DALK due to keratoconus are in the short term add thickness to the host cornea and obtain low magnitude and symmetrical astigmatism below 5 diopters, and in the long term try to reinforce the host cornea. Well, so we decided to perform this retrospective study, which included patients with keratoconus who were candidates for DALK. In the sample, we analyzed 48 eyes from 48 patients with a mean age of 36 years and a follow-up period of 5 years. Regarding surgery, as you can see in this video, a conventional 8 mm trephination is performed. Then we continue with a manual dissection of the stroma, starting from the edge of the trephination and using the Anwar technique. We try to left a residual depth of 50 or 75 microns measured by ultrasonic pachymetry, and then we make a peripheral pocket of 8.5 mm where we introduce the neo-ring. And finally, we place the donor cornea, which will be oversized around 0.25 mm. We finish with the normal sutures without including the neo-ring within the suture. Well, no intraoperative or postoperative complications were observed in all cases, And regarding the results, if we start talking about visual acuity and refraction, as you can see here, the efficacy index was good but lower than 1, because it cannot be considered a refractive technique. But we can see these improvements in the mean corrected distance visual acuity over the years. On the other hand, if we focus on the safety index, we can see that it is greater than 1, so we can say that this is a safe modification of the surgical technique. And all patients improved their corrected distance visual acuity with no loss of vision after complete removal of the sutures. Well, if we focus in the refractive and keratometric astigmatism, both improve in all cases during the follow-up, with a refractive astigmatism lower or equal than 4.5 diopters in a 97% of patients. Only in one patient we obtained a refractive astigmatism over than 4.5 diopters, and was a patient with a very thin peripheral cornea and with a decentration of the trephination. However, we were able to treat this astigmatism with an intracorneal ring segments, as we published in 2023. Well, regarding the endothelial cell density and the intraocular pressure, both were stable during the follow-up, as you can see here. And if we analyze corneal aberration in general, they were comparable to those published in the literature. So we can say that neoring allows us to obtain spherical aberrations values within normal limits, and this indicates that we can obtain corneas with a flatter keratometry values. And if we analyze the biomechanical properties, the host cornea with the neoring is more rigid, so neoring provides greater corneal stability, lower deformation capacity, and greater corneal stiffness, as you can see in this slide. Well, if we analyze the complications, we have not found any complications during short-term follow-up, such as folds, anterior or posterior steps, or any disorders of the ocular surface. Neither have we found any complications at 5 years in terms of recurrence or progression of keratoconus. Now, if we focus on the thickness consistencies, we can see that the host cornea with the neoring was always greater than the donor cornea, avoiding the posterior step. So, without the neoring, the thickness of the donor cornea is always greater than the thickness of the host cornea. For this reason, no significant previous or subsequent steps have been observed. Well, regarding the discussion, there is a mixture of content and concepts in the literature that must be taken into account when comparing results in patients with DALK. Before comparing the results, we must consider the different surgical technique and different pre-existing conditions. Therefore, if we compare our results with those in the literature, they are similar than those obtained by Salotti et al. In a similar sample, but using large trephination. And it is really important because the options currently described for preventing complications in patients with DALK due to keratoconus refer specifically to the surgical technique, mainly the use of different diameters in the trephination. Some authors prefer to use the same diameter between the donor and the host. Others prefer to use large diameters to reduce keratometry and folds, and other authors prefer to use the femtosecond laser, but remember that it can only be used if in the early stage of keratoconus. So as conclusions, neoring in DALK due to keratoconus is a recommended procedure with an acceptable modification of the surgical technique. Thickness inconsistencies are avoided, and good morphological and functional results are obtained in the medium term, so it is considered an effective and safe technique. Only over the years we will see if it prevents dyscharacteria. Thank you very much for your attention.
Very good, thank you, Belén. And now we have opened the discussion to all these nice presentations. I want to thank again Heykel Kamoun, my good friend for many years, to be here. And do you want to start with any question to any of the speakers? Heykel?
Professor Alió, how are you? Fine. So my first question will be for the first speaker. Why you didn't associate cross-linking with rings in young patients? Why do you compare two groups intracorneal ring versus cross-linking?
I think, Belén, if you want, take the question. Luis is not with us.
I can
Yeah,
hear you.
Luis Fernandez Vega is not available.
Yes.
Okay. So my
Can
question
you-
for
No, probably Belén can answer. Belén, do you have information?
Yes, we don't compare our results with cross-linking because it's not our daily practice. But of course, I think that is the most important thing. We need to, now with the new cross-linkings, with the customized cross-linking, maybe we follow this classification with these phenotypes would be really interesting, because sometimes maybe if we combine both, or in some cases could be better,
Yes.
or who knows, in some cases both could be improve the results. Completely agree. Yeah.
I have a question for you. For neo rings.
Yeah.
We can do it in pre-dysmetic, in big bubble technique, or not? Because
Yeah.
you show a video in deep lamellar keratoplasty, not pre-dysmetic.
Yes, we prefer to use this predystematic technique because we feel more comfortable, and we also think that the biomechanical, and there are some publications about that is better, or would be better in these cases. But of course, you also can use this near ring in patients only if you use the big bubble with a dystematic technique. You should be careful because we need to perform this pocket, this peripheral pocket, and you have the dystematic membrane. Maybe you could have problems, but of course you can. And would be great. Even in patients with PK, you can also use this near ring if you perform like this pocket in the periphery.
And in PK, the suture, we will add the neo ring on the suture or not?
No, it's not necessary.
We put it deep.
Yes,
and that's it.
Yes, you perform like a DALC. You create this pocket, and then you finish with the PK, and you suture the new cornea.
Okay.
Yeah.
Nice device.
Thank you.
Very good. I would like to make a point here, because as far as it is demonstrated, and actually we demonstrated that intracorneal rings do not stop keratoconus. They mold the cornea, but they don't stop keratoconus. At least in my practice, we always associate cross-linking to intracorneal segments in pediatric age. And I think that this is one issue that probably I would like to ask to you, Belén. Why don't you use cross-linking with intracorneal segments in pediatric age, which is such one of the best indications?
Yes, as I mentioned, maybe in these cases, now with this new customized cross-linking, we could get better results if we combine both in some cases. But our experience is really good, as you saw in our results. So we feel really comfortable with intracorneal ring segments. But of course, in some cases, we can combine both. Maybe the results are going to be better.
It is my opinion, with all my respect, that should be associated, because the disease is there, and disease in a kid will be evolving. It will take years, but will be evolving for sure. So that is just a comment, And to Gordillo, thank you, Carlos, for being with us today from so far away, right? And well, you showed quite a nice presentation about Cairs and intracorneal rings. You see now that today we have this variety of intracorneal rings, and indeed these asymmetrical rings are really good. The progressive rings makes a lot of sense, especially when the astigmatic axis and the comb axis are not coincidental. And this is one of the points that, in my opinion, cannot be done with the Cairs. I think that Cairs has an indication probably in thin corneas, but probably the rings, the traditional rings, or especially these new ones, have a better indication even today, with Cairs on the stage in keratoconus. What is your opinion now following this presentation?
I completely agree with your comments. Like as I present in my class, the numbers of patients where I use the PMMA intracorneal rings, it's still the same. So no changes at all in my indications, since the predictability of the intracorneal rings is still there. but I have been starting to use the Cairs 3 years back, and the results in the cases that in the past would be a DALC are amazing. And that's why in my practice, we reduce the DALC and we increase the Cairs indications. We also do customized Cairs. So it's kind of an asymmetrical intracorneal ring that you customize for each kind of phenotype. We don't have a nomogram still for Cairs, but well, I think it's gonna be sooner or later in the nomogram available. But so far, as you said, the intracorneal rings is still my first selection for early stages of keratoconus. I have also one comment for the pediatric cases that Luis was presenting. In young patients, when they don't need intracorneal rings yet, maybe the cross-linking is also a necessity. Or before doing the implantation of the intracorneal ring, we also maybe need to perform cross-linking, at least in Latin America, where the genetics is completely different than in Europe. That's why I've seen the results that they have, and with no progression with the intracorneal rings, that's not happening here in Latin America because it's completely different, the genetics.
I have a question for Belén regarding the NeoRing. It's an interesting device, but it's true that as far as I could see in the article, in the study you've done, it's not comparative in the sense that these are cases with the NeoRing, but you are not comparing with DALCs by the same surgeons without the NeoRing, no? And as far, while you don't have that info, you are not really fully proving, no, about the utility of the device. I'm not sure if you have maybe some information from your own center before and after the NeoRing. It has really made your practice and your outcomes better.
I completely agree, and it's like the second step. We are going to compare our results in patients with keratoconus without NeoRing 5 years before the surgery, and we are going to compare both results. I think that is going to be really interesting. In our opinion, the astigmatism is more irregular if we don't use this NeoRing, and also we need to perform all these biomechanical studies and all these things that would be also really interesting. We need to compare both, yes.
Okay, finally, I want to ask Heykel, Kamoun, about these progressive rings, which is, as I mentioned to you, a great idea. Do you use only one, or do you associate two in the different area? Because the logical use should be only to use one, right?
Yeah, yes, in DAC morphology, it's always one. But when you have snowman, when the steepest axis is perpendicular to comma axis, in 90 degrees between them, we have to use two asymmetric rings in snowman morphology.
Do you have any nomogram for this?
I developed a nomogram for this. It's available.
Okay, thank you. Well, any other question from the speakers? Jorge? Well, I think that is an open topic. I'm sure that next year keratoconus will be much more a debate even, you know, because the new emerging techniques, the results of the new cross-linking protocols, the results of the new intracorneal resections Cairs, this is pushing forward corneal surgery, and definitely keratoconus has been the main stimulus that we have had until now to push corneal surgery to a better level. So I want to thank all of you for this extremely nice presentation. I want to thank this leader in intracorneal resections worldwide, which is AGL. AGL is definitely a Spanish company. We're proud of it, and I congratulate you for putting together this session and for this new generation of segments that will improve the potential of vision of workplaces. So thank you very much, and thank you, Heykel, for your co-chairmanship with me. And the session is closed. Thank you.